Myself, Dr. Sudhir Kumar Sahi, heading the Department of Cardiothoracic and Vascular Surgery in Santinandar Hospital. It is also called known as Sir Gangaram Hospital of East Delhi. It is a very old hospital, 25-year-old, just celebrated its silver jubilee, and we are heading the department here in cardiothoracic and vascular surgery. My Dr. Sahi, MCS CTVS from the Equant Hospital. Formerly, I was working in the Sir Gangaram Hospital as associate consultant cardiac surgery, later National Heart of Institute. I also started cardiac surgery in Dehradun at Synergy Institute of Medical Sciences and Prem Hospital in Panipat. Here, since last 2 years, we are working in this department and doing very well. Actually, we are right now talking about the pulmonary arterial hypertension. It is a very debilitating and I think well-known disease in the society, and mostly people remain undiagnosed. They remain symptomatic, but no doctor or physician can anticipate that he is having pulmonary hypertension. A lot of ignorance about this disease, and the patient come to us at late stage, and then we diagnose as the pulmonary arterial hypertension. Pulmonary hypertension is just like systemic arterial hypertension. There are two circulations in the body, one systemic, one pulmonary circulation. Hypertension in pulmonary circulation is known as pulmonary arterial hypertension. This can be acute, this can be chronic. Acute pulmonary arterial hypertension, it can occur because of any embolized thrombus from the leg veins. Major embolus can dislodge and come to the pulmonary artery circulation. It can block the pulmonary artery or major lower branches, lead to acute pulmonary hypertension. It's a dire emergency. We have to treat it very aggressively. We take help of anticoagulants and we monitor the patient, keep the in ICU, and sometimes we have to explore the pulmonary artery to extract the pulmonary artery clots if it is major, and simultaneously the protective mechanism to prevent the further dislodgement of systemic vein thrombus. And secondly, there are chronic pulmonary arterial hypertension. It is known as CTEP, chronic thromboembolic pulmonary artery hypertension. It is very known mnemonics, and for this cause are the DVT patients, and the chronic bombardment of a small emboli from the leg veins to the pulmonary arteries, leading to development of the CTEP, and the patient become breathlessness. I will tell about the symptomatology later on. And these all are the secondary pulmonary hypertension. One major classification is primary pulmonary hypertension. Without any detectable cause, they have pulmonary arterial hypertension because of intimal hyperplasia or intimal disease of the pulmonary artery. This intrinsic disease of the pulmonary artery circulation. And the secondary hypertension, as I told you, acute and chronic, and these are the because of thromboembolism, and some left-sided cardiac problem can also lead to pulmonary arterial hypertension. They manifest initially as a left-right shunt, leading to more pulmonary blood circulation, and initially it is dynamic hypertension, later on it is again static hypertension in long term, like by birth left to heart shunt disease like TGA, large VSD, and lots of them, and also ASD later on if you don't treat it, more pulmonary circulation, and leading to firstly dynamic, then static. You can tell it as Eisenmenger syndrome. This reversal of shunt because of pulmonary arterial hypertension. Here pulmonary artery pressure becomes higher than the systemic circulation, and reversal of shunt takes place. These are the things. Here the right side heart is overloaded, left side heart is empty. So we feel hepatic congestion, pedal edema, raised CVP, And on the other hand, because a low cardiac output, so patient do feel fatigue, lethargy, weakness, uh, and sometimes syncope even because of low blood pressure. Because systemic blood pressure goes down and right heart pressure goes up. These are the symptoms of the patient. They have tachycardia, tachypnea, chest heaviness, lethargy, dyspnea at rest even, and they become so much debilitated. They won't able to do their routine works. So they come to us, we do evaluate them, and we treat the primary cause, which is leading to pulmonary arterial hypertension. There are a lot of drugs, convalescent drugs, which they causes pulmonary artery dilatation, leading to some sort of cure of pulmonary artery hypertension. And primary cause where the pulmonary artery spasm is the primary cause. They get relaxed them and patient get relieved. So they are very very useful. These are pulmonary artery hypertensive drugs. You must know them. A few of them is sildenafil, palmofil, the salt is pretty unknown, and Ryosi and Mesitant, Tadovas, all are the anti-pulmonary artery hypertension drugs we do use in the patient, and we do keep the patient on anticoagulant for long term to prevent the leg vein thromboembolism. So, uh, briefly, I have talked about the pulmonary artery hypertension, the primary, secondary, acute, and chronic. What are the symptomatology? How we do investigate? We can do CT, pulmonary angiography, with a VQ perfusion scan, and of course 2D echocardiography, leg vein Doppler study, D dimer to know the thrombotic propensity, and we come to conclude that patient has been pulmonary artery hypertension. Then we treat the patient mainly on pulmonary vasodilators and anticoagulants. Okay, thank you so much.